Good afternoon, everyone. Welcome to this meeting of the Leicestershire Health and Wellbeing Board. This meeting is being broadcast live via YouTube and it will be archived so you can view it afterwards. Please remember to turn your microphones on when speaking and turn off afterwards. We move on to apologies. We've received apologies from Councillor Cheryl Cashmore and Dr. Nikhil Mahatma and Jane Moore. Is there anyone else? I know Mike Sands might be a little bit late. He's on a national meeting at the moment. Item 1, minutes, pages 3 to 14. I propose that the minutes of the meeting held on the 5th of December 24 are taken as read, confirmed and signed. Is everyone okay with that? Thank you. Item 2, urgent items, there are none. So we move on to declarations of interest. Do any members have any interests they wish to declare in respect to items on the agenda, please? No, can see none. Hello, Kevin. We now move on to my position statement, and you have had copies emailed to you, and a version's also published on the Council's website. I'm happy to take any questions. I will say that I attended quite a wide range of engagements across system, place and neighbourhood. We now have a new section of key messages within the statement, and this provides feedback on actions since the last meeting. Actions and decisions from previous health and wellbeing meeting excuse me, have been presented to the mental health subgroup and the Staying Healthy Partnership subgroup and have been well received. And I'd like this to be a regular item on all the subgroup meetings going forward. It really does help with that constant movement of exchange of information. You can see from the statement that adult social care and the NHS are still facing very high demands. And it not only affects the residents and patients, but also the staff, and retention and recruitment is challenging at present. Over the past year, we've had a very good series of Health and Wellbeing Board development sessions, and we hope to be organising these sessions on a biannual basis to maintain momentum and to foster collaboration. I do ask if you'll complete a survey that will be circulated after the meeting to share your thoughts on these sessions and to help shape future ones. I do feel they are really important way of getting detailed discussions, open and honest conversations and actions that can be taken forward. So I do value those. Could I ask that you send any future agenda items for Health and Wellbeing Board to Abby for the forward plan, please? And I'd also like to remind you that the Health and Wellbeing Board annual report can be accessed on the Health and Wellbeing Board website, and the link is attached to the position statement. And finally, a reminder that Every Contact Counts training is available for all board members. So please let Abby or myself know if you want to take up that opportunity, please. Thank you. Is there any questions on the statement? No, thank you. Move on to item 5. This is the Integrated Personalised Care Framework, pages 15 to 20. This report provides an update on progress in relation to the framework for integrated personalised care and the redesign of the training model which underpins it. To present this report, we have Alison Kane, Cheryl Bosworth, sorry, and Tracy Ward. I suddenly looked and thought 2 people instead of 3. Can I pass that over to you now then, please?
Thank you. Just to give some policy framework and previous decisions, the revised integrated personalised care framework was implemented in October 2022. It was a revision of the health and social care protocol that was devised in 2014, and there have been a provision of health and social care protocols for probably about the last 30 years. So following the development and launch of the framework for integrated personalised care, the Integrated Personalised Care Board, which is the governance and oversight for the framework, decided that the current arrangements for training required a review, specifically due to the legacy nature of the existing training programmes being in place, that there were no explicit contract or service specification or formalised key performance indicators that currently existed between the ICB and Leicestershire Partnership Trust who deliver that care. So in respect of background information, the purpose of the framework is to support the undertaking of tasks on behalf of partner organisations and agencies in a way that is safe and appropriate and equitable. This is a reciprocal arrangement between health and social care, meaning that staff from each organisation can provide either health and social care as part of the delivery of support for people achieving relevant outcomes. All staff who will receive appropriate training in relation to their delegation of healthcare tasks, and that's either generic tasks or specific tasks, and those staff will be assessed as competent in relation to the task before they're asked to deliver them. So just moving on, the framework comprises of two parts. There's a part A, which is management guidance, and part B, which is practice guidance, which is more relevant to the delivery of work by individual staff members. There's a link that's attached to the document in respect of that framework. Recently, the Integrated Personalised Care Framework reviewed information based on a Department of Health and Social Care and the Skills for Care report around delegated healthcare activities, the guiding principles for health and social care in England. It was concluded that the Leicestershire and Leicester and Rutland principles and the standards are in line with the national guidance. However, there was a decision to review in respect of that. And that component comprises of, we'll revise our local framework to embed and reference national principles in all our documents, including packs on websites, so that the legal basis and frameworks and resources are clear, and it's not just a local decision, but agreed at that kind of national level. And our local document will need to have more around specifically how we apply the principles in practice relating to those components. And again, there's a link to that national documentation that was published in 2024. So I'm going to hand over to Cheryl now in respect of the components of the training model and how that's being revised, and then also responsibility for clinical oversight in respect of delegation of specific tasks from health partners to social care.
Thanks. So what the Task and Finish group did was we really looked at the generic framework for delegated healthcare tasks and reviewed that framework and agreed it across health and social care. And one of the things we looked at was how the delivery currently works is it is face-to-face delivery, and people will come in, have their training, be assessed as competent, and then can go. It's not particularly the most efficient or effective way of delivering it. And what we looked at was within our system, we've got some very big care providers that have their own registered nurses on site. And we were looking at whether there was a way in which we could allow those providers to be able to train their own staff, because we're very aware that the turnover of staff is very quick, and once you've trained some staff, a few months down the line, we'll be back in that same position. We've agreed a train the trainer pilot with Rushcliffe Care, which is one of our big providers. Leicestershire Partnership Trust are working with them on their generic training pack to make sure it's in line with our new framework. And then we'll assess those trainers as competent to be able to deliver that training to their own staff. They've got a plan in place sort of for the next 7 months to be able to assess and review 2 sessions per week with 24 participants per month, and then we'll have a look at how that's gone, and on the basis of that pilot, whether we can then roll that out to further providers. We'll be collating the feedback and reviews on that. There isn't any cost associated with that at this point, because Rushcliffe are keen to do that themselves. It saves them time and money. They don't have to release staff to come to LPT to have the training. In terms of the delegation then of the clinical oversight of the delegation, depending on what the task is that's being delegated, the oversight will be different. So obviously, if people are open to community health services and they already have secondary care involved, they will continue to have the clinical oversight of those tasks, and they will be referred back to those services if they require any additional support. Sometimes people will only be open to primary care, and it will be down to the patients, if they're not in receipt of community nursing or therapy, it'll be down to the GPs or the integrated neighbourhood teams to continue to have the oversight of those tasks. If as part of care planning there's an MDT involved, the MDT will make that decision to delegate some tasks to social care if they feel that there is they can be delegated and there's no clinical kind of risks around that. But it must still remain with a clinician, so there must still be someone that has oversight for those. Just in terms of contractual oversight and performance management, we've got a contract in place with LPT at this point in time. Obviously, as part of the task and finish group, we've reviewed the service specification, and we're planning on working with them to redesign the service to see if there's a way in which we can deliver it in a more cost-effective and more efficient way. And we're hoping to look at potentially for some of the generic tasks to be able to deliver those in a kind of online way, potentially with still competency being assessed at the end. Section.
I don't think so. Just picking up on the resource implications, delegate healthcare training component is funded through the Better Care Fund as per details that are outlined with contributions from the city and ourselves. There's a timetable that outlines just to highlight the key risks. So the key risks are highlighted as the existing budget may not be sufficient to meet demand, therefore poses a risk if health may not be able to safely delegate to social care, and therefore the work of the framework, and the lack of capacity within health to deliver tasks if social care providers no longer accept the delegated task. This is offset by additional money that was put in, identified in respect of the discharge grant uses of last year. So that's the kind of components related to the report.
Thank you. Anybody have any questions? John?
Thank you. Thanks for the report. A couple of questions from me. So the first one is in relation to clinical governance, clinical oversight. So whilst I am fairly confident, fairly assured that, as you say, where community health services are involved with the person, they will retain the clinical oversight for the delegated tasks. And less assured where that's not the case, and particularly where people are discharged from acute hospitals with delegations in place. And I suppose I just want some assurance around the notifications that go to primary care and whether primary care are actually aware that they are clinically responsible for those delegations. That's the first question. Do that one at a time, or? Okay, so the second one is in relation to funding, and it's not the funding for the training. It's more about, as I understand it, the delegated activities, if they are sort of incidental to social care delivery, we don't recharge the NHS for delivery of those. We just do them because we're there, so we do the task. But where they require additional time or additional services to be commissioned, we recharge NHS for those tasks. So I'm just wondering whether or not the decision by the ICB to cease shared care funding is going to impact on the integrated personalised care framework and whether it's going to create a risk to the delegated functions that are currently in place.
I'll let Cheryl pick up point one, but I'm happy to be involved in point two.
Yeah, I mean, if someone's coming out of an acute specific delegated healthcare task, and we would ensure that the training took place. I think if you're talking about just if they're coming out and they're only looking to primary care, it would be the same with anyone that receives primary care. If someone has medication, they would ensure that the person is safe to be able to take that medication, and if they're not, they would put other means in place to support. So I'll look at my health colleague over there to help me out. But if for example we required a dosset box, or if we required some other support to enable someone to be able to take the medication, it would be the same as it would for anybody that's receiving general practice care. Is there anything else that
Sorry, Rachel, before you come in, Rachel, I think the question is where there are delegated generic healthcare tasks, how do primary healthcare retain that clinical oversight? So it may be that somebody requires post-operative eye drops, for example, and how is that oversight of that delivery and clinical responsibility retained within primary healthcare services?
Shall I come in on that? I know it's an area that we've had concerns about previously, and we've also had concerns about patients who have been discharged from community health services and primary care picking up that oversight of the delegated tasks. I think it is much more clear now in terms of the shared care records and in terms of that handover procedure to primary care, and within the patient's notes on a record, it is identified where there are delegated health tasks. So I do think that progress has been made on that. I wouldn't be able to give absolute assurance for 126 GP practices today, but I think it's a really valid question, and I think it warrants me taking that question back to primary care colleagues, just in terms of their level of assurance on this, and I'm happy to do so.
Thank you, Rachel. Anyone else? Kevin? Oh, sorry, second question, I apologise.
Ron, I think you're absolutely right in respect of the concern around not having the current arrangement for shared care. It was one of the things that we developed as part of the revision of the health and social care protocol and the placement of the integrated framework. That there is a structure to have that arrangement in place around funding and information about what tasks are being delegated. I think no longer have that arrangement in place. That would compromise the framework and what that might mean about people having to care or residential and nursing care providers potentially having to be delivered. I don't know, Chair, if there's any.
I think that the undershared care to look at what and look at whether they could be supported through a framework that we've got in place. Will be looked at in terms of whether they could be joint funded. Or I'm aware that there are some that have already been funding. So they will all individually be looked at. I suppose the question going forward is whether we need to look at what is delivered through the community services and whether that is meeting a need, and whether there are any gaps in that commissioning where we should actually be expecting those people to be delivering those services and they're not, and which is why they come through shared care. So I think that's part of the review that we'll be doing.
Yeah, so, if I may. So I think thank you for that. I think that it's reassuring to know that each of the individuals that's currently in receipt of a service will be reviewed and appropriate alternative provision put in place where that's required. I suppose the question then going forward into the future is, if that arrangement no longer exists post-April, have we done an impact analysis to understand the pressure that would then bring to community health services, because local authorities won't be commissioning those services in the future?
So there has been an impact assessment completed, and it's been shared with the integration partnership, John. But I think that it's difficult to know at this point until we start reviewing some of those cases what that impact might be, because for some of them we can see that it's a very straightforward additional call to a package, whereas some of them are more complicated, and we've identified that they might have ongoing conditions that we would need to fund through continuing healthcare. So I think it's really difficult at this point to say what that impact will be until we start reviewing some of those.
You did say that an impact assessment had been done, though. So how do you do it without?
An impact assessment has been done in terms of the impact that it might have on the individuals, because what we're not going to do is just stop people's packages and risk those people not having the support they need. So we've done the impact assessment on the information we've currently got, which is we've got 300 and something people on that pathway, and we will be still continuing to keep them on there until we do that review process. But it's difficult, like I said, to know until we've completed all those reviews which pathway they would then be able to go on to.
Kevin.
Thanks for the report. Really good to see it. Just a quick question. It's probably my naivety still getting my head around some of these things coming to the board now. But obviously the risks you're talking about, some of the funding and potentially, what that will mean. Is there a reason why Rutland aren't contributing?
Rutland have, to my level of understanding, a integrated delivery model. So there's not that need for delegation between health and social care or social care and health. They were part of the arrangement until I think the revision started in pre-pandemic stages. And then obviously the kind of revised framework being in place in 2020. Hopefully that's able to answer.
Fiona.
Thanks, Chair. Just as a quick intro, perhaps, for those people that haven't met me before, my name is Fiona Barber, and I'm been kindly invited here to sit as the Health Watch Leicester and Leicestershire representative. So it's very nice to be amongst you all. My background, for those who might be wondering, is in the public sector. Initially, policing was my first career, and since then I've worked through voluntary sector as director of various services with local authorities, consultant around housing and antisocial behaviour, NHS England on the strategic primary care oversight group and specialised commissioning, and also most recently, prior to the introduction of the ICS's deputy chair of East Leicestershire and Rutland CCG. So, and previously I have been part of Health Watch up until about 2018, and then I was a full. So that's my background. If anybody would like to say a proper hello and you have time after the meeting, I'd be absolutely delighted. So that's me. In terms of the question, it's just really around the training, because the national principles and the guidance are really clear and strong, and I think that's a really good guidance for us to look at. Most of the clinical regulatory bodies around nursing and do recommend involving patients and their carers in the development and delivery of any training to do with patient-facing delivery. So I wondered, have you thought of that, and where is that within this particular set of, where is that in this particular offer? And how will patients and their carers be made aware of the update to the framework? And following that, these things are always living organisms, aren't they? So how will patients and carers be able to feed back their experience to influence the future development of training and delivery?
Sorry. What the agreement to do so, people would have the right to say no. I'm not happy that it's a trained organisation, therefore refuse that. And I think we have had examples of that, haven't we? Any kind of future development, I would expect that we would.
To make sure that the development is a continual process. That's great. At one point, Chair, I can't access the Leicestershire SharePoint, so some of the documents in the paper here I can't view and comment on. That's something perhaps we can address outside.
Thanks for pointing that out. We'll sort that for you. I can't see any more questions. I would just say that it's really important we get this right, you know, for the staff. Staff need to feel safe and secure in what they're doing. I see the timescale is for another year yet, though. So have we got things in place to ensure the staff now are trained sufficiently for what they're being asked to do at this moment in time?
We do. The current training module continues, and we receive information from Leicestershire Partnership Trust in respect of the number of providers who attended and the individuals that have attended. One of the other things that I just need to make clear is that organisations and the organisations that they work for don't necessarily have to accept the delegation of healthcare tasks. So if they feel that they don't have that level of input or not have the training, those tasks should not be delivered. So that's the kind of fail-safe in respect of that.
Thanks, Tracy. So we're asked that the updated progress in relation to the framework for integrated personal care and redesign of the training module is noted. We're happy with that. Thank you. We'll move on to, thank you for that report. We'll move on to item 6, which is the Leicestershire and Rutland Dementia Strategy, pages 21 to 26. This report provides information on the dementia strategy and provides an update on the development of the Leicestershire Dementia Strategy Delivery Subgroup. Ben Smith and Kate Revel will present this report. Thank you.
Good afternoon, everyone. I'm Kate Revel. I'm the Head of Service in Adult and Communities Department, and this is Ben Smith. I'm going to present the report.
Yeah, so hello everybody, I'm Ben Smith, I'm Lead Commissioner at Leicestershire County Council for Mental Health, Dementia and Carers. Obviously what we've come to talk to you all about today is the Leicestershire and Rutland Living Well with Dementia Strategy 2024 to 28. Obviously presenting the information and also just talking to you about the development of the Leicestershire Dementia Strategy Delivery Subgroup and the action plan that's currently under development. So initially, just to, I've got my microphone on, yep. Just talk about the policy framework and previous decisions taken by Health and Wellbeing Board. It's important to say this is the third Leicestershire and Rutland Living Well with Dementia Strategy. The previous strategy was initially in place to run from 2019 to 2022. That was developed in partnership with key stakeholders across the area, so Leicestershire and Rutland, public consultation, as you would expect, and cabinet approval. It was underpinned, as is the new strategy, by the guiding principles for the NHS Well pathway for dementia. So, as I say, the new strategy continues to follow that pathway. That was first introduced in 2020 in the Prime Minister's Challenge on Dementia, and it's really well understood locally, I think both within local authority, but also the NHS and our voluntary sector partners. So this strategy has been developed by the 3 local authorities, the Integrated Care Board, NHS providers and local voluntary sector organisations, including Healthwatch Leicester and Leicestershire and Healthwatch Rutland. A bit of background. So due to the unprecedented circumstances caused by COVID, it was decided by the LLR Dementia Programme Board, who are responsible for supporting and monitoring the strategy's action plan, to extend the previous strategy through to 2023. So the current strategy aims to be in place until late 2028 and sets the priorities across Leicester, Leicestershire and Rutland for the ways in which we can support people living with dementia, their families and their carers. It's really important to note that there's a very strong partnership locally within the Dementia Partnership Board, Dementia Programme Board, and that will continue to highlight, influence and manage the dementia strategy and, really importantly, to be able to monitor its progress. So in terms of the vision for the strategy, it's very much to create a health and social care system that works together so that people living with dementia and their families and carers can move more towards personalised and integrated care to support them. And that's, not only prior to diagnosis, but post-diagnosis right through to end-of-life care. The strategy really considers that the impact that dementia has on people's lives, and there is a real commitment locally to, as far as we can, minimising the impact of dementia by providing the best possible care, support and information to people at the right time in their dementia journey. So what we're aiming to do is really to promote dementia awareness and understanding across society. It's really to ensure inclusivity of all people living with dementia and their carers, and that they're able to equally access services. I think one of the key developments in the new strategy is really going into that sort of more localised flavour. What's right for Leicester isn't necessarily what's right for Leicestershire in terms of delivery and Rutland. So what we've done, and this is a relatively recent development, is to ensure that we're developing subgroups. So as you'd expect, there's a delivery subgroup in Leicester, Leicestershire, and then Rutland. And that's really to ensure that the objectives are delivered, monitored and measured, and then reported back to the LLR Dementia Programme Board. It is the LLR Dementia Programme Board that has that overarching responsibility for ensuring that the strategy is delivered. And each local authority area is creating a delivery plan to track that progress on delivery. And I think it's something that we'd be really keen to report back here on a regular basis. So in terms of the development of the subgroup, we have had the first meeting that happened just before Christmas, so last year. And each member of the subgroup has been tasked with reviewing the draft action plan that's been created, and to identify how their organisation is going to contribute to the delivery of the strategy, delivering on the aims and objectives. A final version of that delivery plan is going to be agreed and signed off at the next meeting of the subgroup before going to the LLR board for sign off there as well. So just to talk about the key areas of the delivery plan that are emerging at the moment for Leicestershire, it's really around promoting that real strength-based approach to supporting families living with dementia. Really important, I think, is identifying, promoting and supporting access to good quality dementia training. I think particularly when we're looking at our care home provision and ensuring that best practice is being followed there in terms of supporting people living with dementia. I think there's a huge amount of work we can be doing around promoting dementia prevention methods, and that is very much going to be delivered with our public health colleagues. All of that information around lifestyle behaviour changes and leading a healthier life can reduce your chance of getting dementia. I think it's really important as well, this came out in the consultation, which I will talk about, but we need to be encouraging opportunities for community engagement, and there's a lot of information now around loneliness and social isolation and its impact on dementia. Improving patient access to the pre and post dementia support service. We have in Leicester and Leicestershire a fantastic dementia support service provided by Age UK. They were wonderful during the COVID pandemic of being able to support people when they were waiting appointment at the memory assessment service, and I think that's something that as a health and social care economy we should support and continue. We'll be supporting reviewing pathways for people who have complex needs. Again, this is particularly around people living in residential and nursing homes when their dementia has progressed, and really being able to work with our providers in terms of providing the best supports to those people who are developing behaviours that challenge. And then engaging with people living with dementia and their carers, so including people with lived experience. I think that's been something that perhaps we've not had as much of a LLR Dementia Programme Board as we perhaps should, and that's a big area for development for us as well. To be involved in obviously seeing the strategy through, but also providing recommendations as to how it can be best implemented. I did want to draw attention to something that I think the Health and Wellbeing Board should be aware of and particularly focused on. And there is a real disparity in the dementia diagnosis rate across Leicester, Leicestershire and Rutland. If you look at the diagnosis rate in Leicester, you've got 77.5 of people living with dementia who have received a diagnosis. Now that is well ahead of the national target of 65.8%. In Leicestershire, we face quite a different position on that. So in West Leicestershire, it's 61.8%, and East Leicestershire, 60.8%. So that is so far below that Leicester diagnosis rate. I don't think we're particularly an outlier, because if you look at a lot of cities, they do have a much higher diagnosis rate than counties do. But I think there's a lot of work that needs to happen, particularly in the rurally isolated communities around the diagnosis rates. It does show that targeted work is required to improve that diagnosis rate. And I think it's really important to see that Rutland, whilst ours are low, they're only at 54.8%. So, in terms of, well, is it due to socioeconomic factors, looking at it from that sort of headline, potentially it's not. And it might be more around that rural isolation. But there is going to be a lot of focused work through the Dementia Programme Board and through the delivery of the strategy that's going to focus on that. A bit more information just about the subgroup that we've developed. It's extensive, includes representatives from all relevant teams within the local authority, so public health, operational colleagues, obviously strategic commissioning, colleagues such as myself. We've got voluntary and community and social enterprise providers, hospice providers, NHS colleagues, both from the ICB and LPT. Got the clinical lead for dementia there, and groups who are now working to amplify that service user voice. The initial meeting was held, as I said, in December, and the next meeting, it says there February. That's actually now. I did want to talk about the consultation exercise that we put into this, because I think it's worth noting. So there was a formal consultation that happened after a significant period of design, and I'm really pleased that Fiona's here today, because one of the things that we did when we were rewriting the strategy, the first things we did was to approach Healthwatch Leicester and Leicestershire, who carried out a fantastic piece of engagement with people living with dementia, their families, their carers. And I think we got far more honest views in terms of going and doing that pre-engagement work by working with Healthwatch Leicester and Leicestershire on that, because rather than somebody from the local authority turning up and saying, what do you think about all the dementia provision at the moment, it was Healthwatch, and I think there's a very different relationship there. So, I was really pleased that we did that. Obviously, then we went and wrote the draft strategy, and then went out to consultation. Now, these numbers might not seem in paragraph 22, they might not seem huge. We had 358 responses in the formal consultation period for the dementia strategy. Now, I've been involved in lots of consultations throughout my sort of working life. That's actually a fairly huge response to get through a strategic consultation. And really pleasingly, we had over 200 responses from Leicestershire. Very high number of responses when compared to the previous dementia strategy. Now, overall, I think the responses were really positive, indicated broad agreement with the aims identified. But some of the key things that did emerge from that consultation that we've then been able to put into the strategy is a lack of joined up working between health and social care. I think really importantly that some staff are not confident or competent in supporting people living with dementia, and I think that's where it comes in around that sort of training offer and making sure that we've got that right. Obviously, a huge information about a huge feedback around what we need to be doing around raising awareness about dementia at a really early time and just making sure that people are aware of those sort of early symptoms. Lots of feedback, particularly from Leicester, around the provision of culturally appropriate support and access across the Well pathway. Came back really strongly as well that the memory assessment service provided by LPT should be referring everybody at that point of diagnosis support service in Leicester and Leicestershire, and also more support for seldom heard groups. And again, that developing a recognised standard of training for all professionals and staff who are working with dementia. Then just looking at implications, there are no resource implications associated with the strategy. None of us have got additional resources to be able to deliver this. It needs to be done within our existing financial envelopes. Obviously, there have been the previous strategies provided as background papers, and yes, I'd be very happy to take any questions.
Thank you, Ben, and thank you, Healthwatch, for doing the consultation and engagement. Mike.
Yeah, thanks, Ben, for the presentation. Just a quick couple of ones. Pleased to see the reference to prevention. There's the public health input. Have you got a link into Active Together as well, thinking about the link between physical activity and vascular dementia?
Fiona sits on the delivery subgroup, so it's something I can pick up with her.
I'd give her a nudge just to think about Active Together's role as well. And then the diagnosis bit, I mean, you're right, plenty of work to do on understanding why. I guess it probably comes down to two main areas. Either the diagnosis of capacity of GPs to diagnose, are they reaching out to patients to diagnose them? Or is it on the other side, is it about people hiding dementia by not getting out of the house and being cared for and unwillingness to seek help? So at this stage, have you got a feel for where the balance might lie in the kind of push and pull, if you like?
I think it's a multitude of factors. I also think we have to consider that the memory assessment service is based almost exclusively at a city location for LPT. I think one of the developments that is happening now is that there are some satellite clinics that have now been implemented. And I think it's going to be really interesting to see if in those areas, are the dementia diagnosis rates increasing there? Because actually it's the service going to people rather than expecting people to come in. I think some of it probably is linked to primary care, and I do think there's still that stigma attached to diagnosis and people not wanting to know. I think it's much easier if you live in the city to go to get to the memory assessment service, and I'm very hopeful that actually these satellite clinics may have some real impact on that. And I think there does probably need to be some work done with GP practices as well to ensure that they are trying to spot things.
Ed.
Thank you, and thank you, Ben. Really interesting, and those stats are striking, aren't they? As you said, the disparity in trying to understand that is really important for this board. Just in terms of, I guess, making every contact count, looking at the membership of the Leicestershire subgroup, and I appreciate it won't be covering everyone. Just thinking about our housing teams, we support 15,000 tenants across Leicestershire, across all the districts, and they will be interacting with people perhaps who may be displaying symptoms of dementia, and do they know what those signs look like? Can they make the right referrals? So I think there's something perhaps, Abby, we can make that connection with the Chief Housing Officers group might be a useful way to kind of raise awareness with them. Also thinking about district health leads as well, colleagues who are interacting with people on other matters, just again might be a way to join some of the dots, and that might be a way to bridge some of the gap that there may be in raising awareness. So yeah, happy to support that, Chair. Thank you. Yeah, Maddie's might be great to link in with, yeah.
Fiona.
Thanks, Chair. Just a question, and this is probably my ignorance, not having seen many of the Health and Wellbeing Board papers before, but at the end of the report, it talks about relevant impact assessments at 26, and it says there are no equality implications arising from the recommendations in this report. And I was just thinking to myself, well, looking through some of the feedback, there is mention of culturally appropriate, the support for seldom heard groups, and I'm just thinking to myself that actually I would, as a non county council stroke health person, I would immediately assume that there are implications in terms around that, and I think perhaps making it or linking the EIA paper to the report so that we can just read through it and be assured as a board that the equality implications are taken care of within the report would be quite helpful, and certainly give me a little bit more assurance that they are. if that's okay. Thank you ever so much for mentioning the Health Watch work. That's excellent. One of the things that always worries me around consultation is that whatever group that undertakes it or supports it, it's like a moment in time. And as you quite rightly point out through the report, the services are being developed, they're being reviewed, refreshed, little tweaks are being made. So there is some kind of thing in my mind around having that ongoing conversation with people who are accessing or trying to access the service, isn't there? So that you've got that constant loop. And I'll refer it, you'll probably hear me say it more than once about closing that loop. And I think it would be quite useful to think about how that might be able to work in this sort of land. And I'm not saying Health Watch will do it every time, but it is something obviously that Health Watch and the voluntary sector are there to support the Council Health with. I think one of the things that I'm asking myself reading the strategy, you're quite right, this is year 9 overall dementia strategies. So how successful have the previous strategies been? You know, where does it, how would I know reading that about the impact of the previous strategies? And what makes you think that this one will be more successful or give better services?
I think the development of the place-based delivery plans and actually really focusing in on those at those delivery meetings and then being held to account by the LLR Dementia Programme Board, but also by groups like this, and actually bringing those regular, say, this is what we said we'd do in 2020, this is what we've done, and having that real focus on delivery rather than just writing the strategy and then going, right, this is what we're actually making sure, and that's what the delivery subgroup is. And that's why one of the things that we did in the initial meeting was set people homework of go away, tell us exactly what you are going to do, what your organisation can do across all of these aims, and then we need to timeline it out and manage that and monitor it and report back on it. So hopefully that might give some confidence, but only when we come back and we've shown that we've delivered it.
Yes, I can see where you're thinking it is going around that. The strategic vision is a nice outline, but actually I think one of the things that the Health and Wellbeing Board has published in its 10-year paper is what does good look like? And I think I don't really get a strong sense out of the papers what good looks like and whether you feel you're getting there. And from a Health Watch perspective, the impact on people in the communities who are about to live with or are living with dementia and being supported, that's key. What's the impact on them? So far, how have you got there? And I think those are all quite important when we're talking strategic direction, particularly one that's been going for such a long period of time. You know, is it right, or should we be doing something else? You know, all those kind of little nuances. I mean, in terms of the Health Watch, previously or recently raised concerns around the Admiral nurses and the provision of them, the funding of that across Leicestershire. And also you mentioned about high demand, there's how that'll be going forward. It's not reducing seemingly, even though prevention is there in the strategy. It doesn't seem that we're actually reducing things, but also we're finding and getting calls to say that the referral to memory clinics is taking a considerable period of time. So these are all things which the strategy hopefully will make better, but we need to make that clearer, I think.
Sorry, just to address that point around people waiting for those appointments at the Memory Assessment Service, it's one of the changes that we made to the Dementia Support Service, because according to the service specification as it was written, they could only start working with people at that point of diagnosis because of those long waiting periods. Have done is change that service specification so that when people have been referred to the Memory Assessment Service but are waiting for that appointment, they are put into contact with Age UK and that dementia support, so that they're able to be supported as they're waiting for that initial appointment, that's been really successful. So given that we are going to be coming up to recommissioning the dementia support service within the next 12 to 18 months, that is a really important development that we really want to do more research into and the effectiveness of that. But that was one of the things spotted and best.
Did you want to come in on that specific point?
No.
No, I'll come. Okay, Jean. Sorry.
Thank you. So I'm Jean Knight. I'm the Deputy Chief Exec for LPT. Very nice to meet Fiona. I think it's an issue, isn't it? And I think the dementia diagnosis rate isn't quite as simple as people may think, because the number of people that can be diagnosed is dependent on the number of people that's added to the list, and that's dependent on who's putting themselves forward and the links in with primary care. So I think the neighbourhood teams will be an absolute step forward in terms of addressing some of those elements. I look forward to that development of that over the next year. I think one of the things that just reading the more in-depth paper that's on the website is just about how we're also ensuring loneliness of carers is addressed, because it's not just the individual with dementia. If you've got, a husband and wife on their own, then that person could not speak to somebody for weeks. I think it's really important that we pick that up. In terms of the waiting times to treatment, absolutely. And, from an LPT point of view, we are picking that up, ensuring that we're referring into that. But the average is currently, I've just checked, 16 weeks, which is not great. And we've got some really long waiters within that. Unfortunately, we did have some non-recurrent funding last year. That's now been pulled, so we won't be getting that for the next year. So the waiting list will continue to increase because of the number of patients that we've got coming forward increasing as well.
Christine.
Thank you. I was glad to hear about the satellite going out. It'd be interesting to come back with what you're finding. I think probably the lifestyle out in Rutland and the clear air may be a big factor, getting dementia and things like that, because I do think healthy living does help in a lot of cases. The other thing is that one of my concerns is that we haven't got the care homes for when you're at the end of your dementia, because we had a couple of family members. You could look after them to a certain time, and then it did get that it was impossible to look after them at home because of how aggressive they got and things like that. So John and I are aware, aren't we, that there is a big shortage of care homes with dementia. And as you all know, I'm lead member for adults, and we do take carers really. We do highlight the fact that we've got to support the carers. Without the carers, then we would be in a more of a dire situation. So it would be interesting when you've got those satellite out to find out whether we are picking more up and things like that. Thank you.
Kevin.
Hi, great feedback report, Ben. Thank you for this. 3 quick things and then a question.
Mm-hmm.
So first of all, obviously, I was privileged to be part of hearing your presentation at the mental health subgroup. And so from that, I know you also mentioned Health Watch. So I have already fed back to Gemma and the team to say a huge thank you to them. So thank you for letting us know about that. The other bits, I suppose, for me really is if you can look about in the delivery plan around things like raising the awareness, getting more information out, can you please loop us in? Because obviously we're sitting on a database of 5,800 members. So we can get more, we can also target and get information out to areas that maybe you might want to do more with or things like that. So that would be great. The other thing, I suppose, is just a bit of a question is under the delivery plan under development, when it gets about encouraging the opportunities for community engagement, reduction in loneliness and social isolation, could I ask whether you could maybe also tag on to that digital exclusion? Because that does seem to be from some of the work we've been doing around loneliness and social isolation. They are starting to go hand in hand with each other. And I think that's something that need to be maybe explored a bit about as well. And then my question, which I did say I'd get to, is just because I'm curious. We always throw around the hard to hear, seldom heard. What kind of groups are we talking about with regards to the consultation that you undertook?
I think that's a myriad of different groups. So obviously in the city, you've got particular communities that don't necessarily engage as much with health and social care bodies. I think in the county, we obviously do have some communities like that. And I think what we need to do is actually engage far more with our rural, isolated communities, farming communities. You know, I think sometimes they can be forgotten with some of this work. And actually, if you look at areas where the dementia diagnosis rate is almost at its lowest, it is in some of those places, very heavy in terms of farming. We're not looking so much at any issue around ethnicity or deprivation, but it is isolation. So I think it's a really, really wide range. But yeah, lots to tackle.
Thank you. I did have, I'm pleased that you've got subgroups for each area now, because as we've said, diagnosis rates are quite different, and we need to address that for whatever reason. And I do think, within Leicestershire and Rutland, there are some diverse communities out there. We've got travellers, you said, farmers, we've got Polish people, the stigma that goes behind all of that really needs to be broken down, and it's how we bring that awareness to those groups. I think as well as isolation and, as Christine said about the care homes, I mean, dementia is very difficult for families to cope with, especially towards the end, and especially if people get aggressive, etc. But also this has a real economic impact as well across, you were talking about it yesterday, that if we can do more in the prevention and the awareness and the stigma, then hopefully we can delay the onset if we can't stop it. So thank you. So we've been asked to note the information provided on the 24-28 LLR dementia strategy and the consultation that informed the development of it, and also to note the information provided on the development of the Leicestershire Dementia Strategy Delivery Subgroup and Action Plan. Could we have a shorter name or something there? That's a bit of a tongue twister, but I hope everybody's okay with that. Yep. Thank you. Thanks for presenting. We now move on to item 7, which is the Joint Health and Wellbeing Strategy Progress Update on Best Start for Life. This is pages 27 to 42. This report provides an update on progress in relation to the Best Start for Life priority of the Joint Health and Wellbeing Strategy 22 to 32. Marla Razak will present this report, and I believe she's online. Hello, Marla.
Hello, thank you, everybody. We've got quite a lot of information in this report, so I'm hoping you've all had an opportunity to be able to read through some of it. I'm going to just pick out some highlights, and then I'll obviously take some questions if I'm able to take them at the end. So if we look through our first priority within the Best Start for Life, it is around the first 1001 critical days. And work has continued to focus on workforce development, raising awareness of the importance of 1001 days for children's development across the children's workforce, across partners. And there's also a communication plan in place to share key messages and practical support with families. So there's a range of work done, including with students of health and social care and midwifery at our further education colleges. There's also been social media activity that's continued, and key messages are shared by partners across a number of platforms. Children and Family Services Family Help, along with the Leicestershire Safeguarding Partnership, also hosted its first baby fortnight that had key messages around Start for Life aimed at practitioners volunteers and families, and there was a range of sessions delivered in family hubs, online, and messaging via social media, which was all very well received, and it's intended to deliver a similar campaign again in 2025. In relation to the commitments around having an integrated early years pathway, a pilot was completed to trial a new mechanism for providers to share where they have concerns about children's development in the setting with their health visitor, and an online questionnaire enables the health visitor to respond with advice and guidance for the parents to use for the child, and a positive pilot has resulted in the work being rolled out across the whole county and trainings being developed for early years providers alongside website materials and bite-sized further training. So looking ahead at empowering families to access the most appropriate health and wellbeing services, we've talked to you before about our family hubs, which are one-stop shops for all families with 0 to 19s or to 25 for young people with SEND, where they provide information, advice, resources and support. So all 21 centres are now launched as family hubs, and 16 county libraries also host a family hub area with information and resources within them. And the Family Hub website for parent, carers, young people and professionals is now well developed and has a range of content for people to be able to self-help over a range of topics, including parenting, behaviour, health and wellbeing and parental conflict. And then another update is around in Melton, the family hubs have been working closely with Latham House GP practice. They brought together health staff with parents of young children attending stay and play sessions at the family hubs. And the health staff provided a range of thematic talks on issues including vaccination and winter illnesses, and they had an opportunity to have that informal conversation with 38 families. The GP felt that the impact of this was that the need for 6 GP appointments was avoided. And good news is that in December 24, the Department of Education announced continued funding for family hubs in Leicestershire for 25 to 26. Moving on to the priority around school readiness and narrowing the gap affecting children who are at the greatest disadvantage. The Children and Family Services, Early Years, Inclusion and Childcare Services has joined with the libraries to deliver book start packs to children in areas of disadvantage. It gives them an opportunity to model how to share books and sharing top tips about reading with providers and parents. There's also a lot of activity ongoing in that area, and in 2025, in April 2025, there'll be an early years conference for up to 80 providers to help them understand their role in promoting the home learning environment. Looking now at supporting families to get their children off to a good developmental start and accessing support to early development of speech, language and communication. We recognise that speech, language and communication is quite a big issue, particularly in our younger children post-pandemic. The Maternity and Early Years Partnership for Leicestershire have identified that speech, language and communication skills remain quite low for some of our youngest Leicestershire children. And as we all know, children with good communication skills are more likely to be ready for school, and partners are identifying the key actions that we can undertake to help promote better speech, language and communication, and particularly targeting parents with key messages for the things that they can be doing to help support their children before they start school. Also, there's a range of communication and language training being offered to support our early years childcare providers working with children from 9 months. And there's also training being developed for the early years workforce to help them identify children at risk of language delay and 86 providers have been booked onto training for the spring term in 25 that's coordinated by the CFS Early Years Inclusion and Childcare Service. Moving on to embedding physical activity in children's lives. There are a range of programmes that have been available, including Healthy Tots and the Henry programme, and 5 programmes were delivered in 23 to 24 in March in North West Leicestershire, Blaby, Oby and Wigston. And then looking at access to high quality, inclusive and accessible childcare and early education. So with the introduction of the expansion of childcare for working parents of 2-year-olds and under by the government, a new campaign for parents and providers is being developed from September 24, and significant work is being undertaken with early years providers to ensure there are sufficient places for the children who are under 2 to enable parents to return to work and training. This has created some new places, but also there is a backdrop of wider issues and challenges in the early years sector that will still need to be looked at, and I'll touch on that a little bit later. Looking ahead at the priority around preparing for life and access to emotional and mental health support for children and young people. LPT's mental health support team in schools continue to roll out new schools with each new wave. We still don't know yet when wave 11 will commence. And accessing appropriate support for children and young people to maintain an active lifestyle and healthy weight. The holiday activities and food programme funded by DFE to target children in receipt of free school meals to be able to access free holiday activities in the Easter, summer and winter holidays was rolled out successfully across 2024, and the really good news is there's been a 1-year extension announced by the DFE, so we'll be able to continue offering that programme across 2025. In relation to supporting the workforce to embed a trauma-informed approach, there has been training for health visitors and midwifery staff using the toolkit through Bernardo's, and that has been worked through with the Violence Reduction Unit. And also just to flag that there was some funding that had been provided to commission this training and employ an LLR trauma-informed lead, which has now ended. So the work of the lead included setting up the trauma-informed network, developing a self-assessment framework for organisations to use as to where they are on the journey to becoming trauma-informed. So this is quite a loss that we'll now feel for not having that coordination role. So system partners will need to consider how we can fill that gap and how we can maintain the momentum of that work. Also that's being rolled out, early help local authority leads across LLR working with the Violence Reduction Unit have developed an early help competency framework to help provide a framework for identifying the skills, knowledge and experience needed to support early help provision across the early help system. So that is going to be launched in March 2025, along with a quick thinking plan as a way of helping those organisations and partners working with families to put together what's already happening, what's already in place and what help is still needed. And then moving on to cross-cutting priorities. Around improved mental health, work has been attempted over the year on developing a protocol for the extension of the CAMS offer to age 25 for care leavers, where we recognise that care leavers may not always be emotionally and developmentally ready to move into adult services. There have been challenges experienced by Children and Family Service, who've been trying to work through this with partners. And the challenge seems to be that we need to identify an appropriate health lead to be able to progress this, because it's outside of the remit of Children and Family Services. So the goal still remains an extension of CAMS to 2020 to 25 for care leavers, but we recognise that this might be aspirational and that there may be smaller steps or other solutions that might be needed in the interim, as this may be a long-term goal. So in terms of feeding back around the developmental session that was held for Children and Families Partnership as the Best Start for Life Partnership Group. The development session was held in June 24 and was aimed at enabling Health and Wellbeing Board members, Children and Family Partnership members and wider partnership colleagues to have a facilitated discussion around this priority, areas of future action and any challenges. Some of the key areas identified for development were around transferring of data, information sharing and communication between organisations, and engagement and communication with communities, workforce development, recruitment and retention, and identifying opportunities for joint working or pooling of resources, and that also included better engagement with the voluntary sector. So we have had some discussion within the Children and Families Partnership following that development session, and there are some meetings scheduled to enable further discussion and to review the Children and Families Partnership Plan to identify any actions that may need to be picked up following that development session, and also including any areas where we feel we may need further help from the Health and Wellbeing Board, and we'll be able to feed back to you more on that when we provide our next update. In terms of next steps, a focus over the next 12 months will be on the early years sector, where COVID-19 has had a real impact on the sustainability of early years providers. That's compounded by the cost of living crisis, and also by the new government initiatives that are around expanding childcare places. So since 2022, 1,749 net childcare places have been lost, despite new places being created in 2024. And the early years sector is also facing a recruitment and retention crisis. In terms of other work that's going to be continuing over the next 12 months, the Family Hubs team would like to look at replicating the Melton GP pilot or developing a similar approach with GP surgeries in other areas of the county, as there clearly are benefits for GP practices as well as families. And also there's a consultation currently underway on the draft Send and Inclusion Strategy for 2024 to 27, which describes how organisations representing education, health and social care will work together across Leicestershire to support our children and young people with SEND. We would really like the support of the Health and Wellbeing Board to help us get that survey out and get more people involved in the consultation. It will close on the 8th of April, and the link to the survey is included with the papers. And it is aimed that the responses will be used to inform the final version of the strategy, which is due to be agreed in June 2025. So that's my whistle-stop tour of that report. I'm happy to take questions, but as the Officer Support for the Children and Families Partnership, I may need to take some of those questions away to priority leads and action leads if I'm not able to answer them for you.
Thank you, Marla. That was quite thorough for us. Thank you. It's a shame that we've only got confirmation for a year extension on the family hubs, but I expect that's while government are looking at how they're going to move forward. Most of the discussion within is from birth onwards. Do we do anything within our family hubs, for example, across health, or the women's hubs from, say, preconception? Because obviously if those mothers are experiencing trauma or whatever, that influences the outcome of the birth, etc. I just wondered if there is anything in place that takes that back a little bit further for more prevention of, more preventative work. Are you aware?
I'm happy to take that question back. I do feel quite confident that there is work that's undertaken, but I'm happy to take that question back and ask my colleagues in the family hubs to provide some more detail for you on that.
Thank you, that would be helpful. And I know you're reviewing your children's partnership or your children and families strategy. At the same time, we're reviewing our health and wellbeing board strategy. So is there a way that we can work together so that we can cross-reference those and make sure that we're linked in, so to speak?
Absolutely. Abby and I are in communication around that, and Abby will be attending some of those meetings that we're having around reviewing the Children Families Partnership Plan. So we'll be able to align them as much as possible.
Thank you. Just a couple more things before I open questions. Sorry, I don't usually go first. You're talking about children in care being referred to CAMHS, etc. Obviously, we know CAMHS is very in high demand, and especially service. Do we inform our youngsters about Tell Me and other things where they can get self-help through apps, etc., which is obviously the way they like to communicate a lot of the time? So are we making sure they've got the backups there?
Yes, I'm confident. Again, I'll go back and ask my colleagues within that team around that information. I'm sure that we are. This is more specifically around when children in care hits 18, they're handed over to adult services, and it isn't always the most appropriate environment for them. We recognise there are challenges within the whole structure of the way that CAMHS is set up as to why they can't currently continue in the children's services, but there are still challenges for those young people who require the kind of support they're getting in the children's world rather than in adult services. But as I mentioned, there is a need for strong health lead involvement to help drive those discussions and that's exploration forward, that we've reached roadblocks really in how we move that forward.
Okay, thank you. I've got two people wishing to speak here. Jean.
Yeah, so I can answer the one about the young people up to the age of 25 and the care and the support that we provide to people that are waiting for CAMHS treatment. So there's a comprehensive website that links through to lots of different options, including things like chat health for people that are at school. Obviously, we've got mental health in schools teams. The next wave, we're out to recruitment now, so that should commence in the next, well, it depends how long it takes to recruit people, but quite soon, hopefully. In addition to that, we have lots of links on websites. All the information is shared through mental health in schools. And in fact, for our crisis team, we've also implemented additional follow-up checks that is new, and it's been trialled and worked really well. So actually, that's reducing our waiting times for young people, because actually, those of us who have young people in our lives know that they'd much rather talk on by text than actually face-to-face with somebody. So we're seeing that improvement. For the children up to the age of 25 who are care leavers, it's probably worth linking in with our looked after children team or getting somebody to Marla, because they currently already support young people up to the age of 25 who are care leavers. We provide both CAMHS and adult mental health services, and we do link in very much with some of the SEND service as well. So it does all link in together. So I'm not sure why you're not getting somebody to help with that. But if you want to email me, I'm more than happy to send it on to get some appropriate support for you.
Thank you.
Thanks, that's very helpful, Jean. Simon.
Thank you, Marla, for the really helpful presentation. Just a couple of things from me. My name's Simon Pizzi, Associate Director of Strategy and Partnerships at UHL. Apologies for the rest of the room, not looking at the rest of the room, looking at you when I asked my questions, so apologies. The first is, if you're a single mother at age 21 or below in Leicester, Leicestershire or Rutland, 95% of occasions you attend A&E at least once a year for a medical condition that doesn't require any treatment with your infant. Now, that isn't to say that that attendance is not necessary, but it does suggest, is A&E the most appropriate place for a single mother at the age of 21 with a newborn for help, which is what they're seeking. But I just wonder if this strategy could look at those first 1,001 days and what support it provides specifically to children of mothers aged 21 or below from Leicester, Leicestershire and Rutland, aged 21. I know it's quite a specific area, but I think it's helpful. And the second point is, a charity Parent Kind released a national survey results this week, which said 1 in 3 children now once a week refuse to attend education, and many are not attending. And I just wonder if that doesn't come across strongly enough in our response to that and to the strategy also. Just a couple of points. Thank you.
Happy to take those back and to feed those through into our discussions around the refresh of the Children and Families Partnership Plan.
Thank you, Marla. Rachel.
Thank you, and thank you, Marla. There's certainly some great work happening within the partnership. I think for me, in terms of forward looking, there's something around those key health focuses around antenatal and postnatal care, around smoking cessation, about weight management, and those areas that are a big focus from a place perspective between public health and ourselves in the ICB. And again, I think it's around how do we get that really strong health focus without destabilising a lot of the work that you're doing around those wider determinants of health as well, and the really important work that you're doing around education and other areas of focus. For me, though, there is something around kind of how we collectively, at a place level, strengthen that focus on some of those health elements. And also, just in terms of the GP pilot that you've done in Melton, we're really lucky in Melton. That's one of our few neighbourhoods that has a single PCN. So I would be really interested in seeing how that model translates into other neighbourhoods where you'll be working with 2 or 3 different PCNs. And I'm really interested from a place lead perspective in just thinking how our neighbourhood model, which we are really keen on developing and strengthening over 25-26, can support some of that work. So just keen that it'll probably be Helen Mather from the ICB that links in with you around that work, but I think it would be really helpful to keep an eye on that and see how much work we can do. And I think that links strongly to Simon's point as well around that growth in children's attendances at ED, and particularly where no significant care is required, and how we help people to see alternatives. Mike, please.
Yeah, thanks, Chair, and thanks, Marla. So whilst we're doing the kind of things to think about next time and catching up on where we are at the moment, is there anything going on in the partnership or being raised in the partnership about, there's 2 separate things, the role of screen time per se on child development and the role of social media on teenagers in relation to their emotional well-being. I mean, you can roll them together because I think it's all about technology, but I think there's 2 distinct groups. And I wonder if that was featuring in some of the partnership discussions and whether that should also feed into the future strategy work.
So we did have, and I'm afraid I forget the gentleman's name, the consultant who's done some work around Screendemic, who did a presentation for us, and we were going to look at, it is our intention to look at how some of those key messages are picked up and shared. So that is already being factored into our discussions. And in terms of the impact of social media around around emotional health, There are some aspects of that are being considered. I know that particularly around our priority planning around helping children to stay safe. There's certainly work that's done with the police around helping children to stay safe on using social media and some key messages. But again, I'm happy to pick that up around emotional health and to feed that back into our discussions.
Okay.
Dr. Nishani is the Screendemic consultant from Leicester.
Thank you.
Fiona.
Thanks, Chair. Hi, Marla. Fiona Barber from Healthwatch Leicester and Leicestershire. Firstly, I'm going to echo colleagues around the table. Thanks for such a broad presentation. I'm not experienced in the world of children and young people, so that gave me a real good insight into the amount of work that's going on, which is mind-boggling listening to it all and reading about it. I guess my questions are a little bit more simple, really, in terms of if I walked up into a families group and spoke to children or parents or carers, you know, would they say, oh, yes, this strategy really works well for me. It's successful in this, that and the other. And what are the real successes of this strategy? And where are the areas that do need changing or developing? Because I get to read some of the outcomes here and I see some measures which show where the county sits, but I'm not clear in my own mind which the really super duper success stories are here and where you're looking to change things to drive things better for children and families going forward. Little things like, for example, the social media messages that go out. Who measures the analytics for reach? How do we say, yes, this is really working for our children and families? It's producing well-informed parents. How can we evidence that? Just to say that these are the right things to do. So there's that element which goes on in my mind, really. And the other one is a bit more specific on the SEND consultation, which is currently underway. I wonder if you could just talk us through how, or the proposals that are being used for actually involving children and families who are part of the SEND world in this particular consultation, rather than just having the survey.
Unfortunately, I'm not knowledgeable enough about the survey and how that's been developed. It's certainly a question I can take back to colleagues in our SEND and education side of children and family services, where this is being generated through the SEND and inclusion board, and ask them to get back to you. I'm afraid, as I said, as the collator and the officer support, I'm not in touch close enough to all of the work to be able to answer that question, I'm afraid, at this time, but I will ask somebody to get back to you.
Do you think you could feed back all those answers to Abby and she can share them out, Marla?
Yes, of course I can.
Thank you. I can't see any further questions, so we're being asked to note the progress made in relation to delivering against the Best Start for Life priority and note the progress being made in relation to delivering against the cross-cutting priorities. And I think I agree with Fiona, it would be nice to have some measurements there so that we can actually see outcomes. So if we can do that going forward, that would be great, Marla, thank you.
Thank you.
I'd like to say that the structure of the report is excellent now. I know we had our ups and downs about how to structure it, and also great to see the good work being progressed in children and families. Thank you.
Thank you, everyone.
We now move on to item 8, which is the Joint Local Health and Wellbeing Strategy Review, the approach and plan, pages 43 and 128. This report provides the board with a detailed approach and timeframe for the review of the Joint Local Health and Wellbeing Board strategy, and Abby Vaughan and Josh Namadji will present this report. Thanks.
Yeah, thank you. New to this meeting. So yes, I'm just going to share my screen because I have got some slides to present as well, just so bear with me. Good afternoon, everyone. So following on from the joint local health and wellbeing strategy proposal report that was presented at Health and Wellbeing Board on the 5th of December, Joshna and I are here today to provide a follow-up report as requested by Board. So the purpose of the report is to present details regarding the approach to reviewing the current strategy and the associated timelines for doing this. So the report presentation and appendices which contain the current strategy can be found in the agenda pack today from pages 43 to 128. A little bit of a background for you. The Joint Local Health and Wellbeing Strategy is a statutory duty of the Health and Wellbeing Board and is jointly owned by all our members sitting around the table here, and our respective subgroup membership as well, who's responsible for delivering those priorities, as we've just had an update now from Marla. So progress against the priorities and commitments within the strategy are reported to Health and Wellbeing Board on either an annual or biannual basis from each of the subgroups. So it is a 10-year strategy, and that was approved by Board in 2022. So we're coming up to the 3-year review now, and that was approved during that proposal that every 3 years it would be reviewed, and priorities and commitments to ensure that they remain appropriate and relevant to the needs of Leicestershire's population. So as you know, the Health and Wellbeing Board have run a series of development sessions over the past 12 months with key stakeholders from the board and respective subgroups. And at all sessions, it was agreed that we continue with the life course approach. So we won't be reviewing that element of the strategy. At the Health and Wellbeing Board meeting that took place on the 5th of December, partners agreed that the key focus for this light touch review should be focused on the 80 commitments within this life course. And the review would commence in February following approval of this paper, and aim of concluding the review of the commitments by September this year, where it will be presented back to Board. So the strategy itself, currently in its format, runs from 2022 to 2032. It comprises of 4 strategic priorities that take the life course approach, 3 cross-cutting priorities, strategic priorities, 10 sub-priorities and 80 commitments, which I will explain in more detail on the next slide, including providing an explanation of what is in and out of scope of this current review. I do apologise for this busy slide, but it is a visual explanation of the strategy. So the bar across the top is the Health and Wellbeing Board strategy. And the second row down highlights the 3 subgroups of our board. So we've got the Children and Family Partnership, where Marla's just presented her update today. We have Staying Healthy Partnership and the Integration Executive. And we have a new place-based mental health group that was launched after the strategy, which delivers on the mental health cross-cutting priority and associated commitments. So this row also highlights the 2 other cross-cutting priorities that are in the strategy at the moment, namely inequalities and COVID recovery, which are also in scope of the review. So each of the subgroups not only reviewing their own commitments, they will also review the cross-cutting priorities as well. So each subgroup delivers a life course priority, as I've stated there, and that will, those priorities will not change. Children and families look at the best start for life. Staying Healthy Partnerships look after staying healthy, safe and well. And Integrated Executive, sorry, I'm getting familiar with all these different words, they look after their 2 strategic priorities, so living and supported well and dying well. And they will remain the same, so won't be touched as part of this review. So each of the life course priorities has sub-priorities, and again, they will not be changed unless during the review it is there is a rationale for changing some of their names or adding other priorities. So it's not completely out of scope, but it's not something that we're asking our members to look at. So for Staying Healthy Partnership, they have Children and Family Partnership have 3 sub-priorities. The first, 1001 critical days, which are underpinned by 6 commitments, school readiness, which has 6 commitments, and preparing for life, which have 8 commitments. Staying Healthy Partnership has 2 sub-priorities, building strong foundations, which there are 11 commitments, and enabling healthy choices in the environment, which there are 9 commitments. And Integrated Executive Living and Supported Well have 2 commitments under that priority, upscaling prevention and self-care, where there are 5 commitments, and effective management of frailty and complex care, where there are 10. And then under the Dying Well sub-priority, there are 3 priority areas: understanding need, where there are 2 commitments, effective transitions, 3 commitments, and normalising end-of-life planning, where there are 5. So along with the cross-cutting priorities, there are a total of 80 commitments that need to be reviewed as part of this strategy, and maybe streamlining some of those commitments and having more focus might be a good approach, but we will talk about that a little bit later on. So the commitments will be assessed as part of the review, and the strategy will not be a full rewrite either. It is light touch, but because of the review itself and what may change in terms of the commitments, some of the text within the strategy may have to be amended depending on what the recommendations are. There are also guiding principles which are within the strategy itself as well, which may have to be tweaked depending on what the recommendations for changes are in terms of the commitments from our subgroups. We also recommend that the governance of the Health and Wellbeing Board and associated subgroups will be reviewed during this process, including membership and structure, to ensure that everything operates as effectively as possible to deliver the strategy and associated priorities and commitments. So once the recommended changes to the strategy are approved by board in September, the delivery phase will commence, where the strategy will be designed and published, and tools such as highlight reports, targets will be set, and progress towards what good looks like in terms of those priorities will be co-designed with our subgroup members. So what is the main purpose of the review? So the main purpose is to ensure that the strategy remains relevant and effective in addressing the current and emerging health and wellbeing priorities of Leicestershire Public. So by evaluating these commitments against the latest JSNA data and other key evidence, the review will identify whether the commitments that are currently in position remain appropriate or not. So it will evaluate, as I mentioned before, the cross-cutting priorities to assess their relevance, whilst providing an opportunity to incorporate new priorities, remove them or embed them. Removing them, for example, we have COVID-19 recovery. Is that appropriate to remain as part of our strategy at the moment, just to provide you with a bit of an example? So the proposed approach, and there are 5 key areas, as I've mentioned: reviewing the 80 commitments and the cross-cutting priorities. The review will be heavily evidence-based, using the most up-to-date JSNA data sets to determine whether the commitments and cross-cutting priorities require updating or changing as mentioned. There'll be an opportunity to introduce new ones, as I've mentioned before, and all decisions for change must be supported by evidence and a rationale. And I'm going to mention about a steering group, but we're going to provide the tools, templates, support and guidance to enable the subgroups to do that work as effectively as possible. And again, reviewing the governance as well, as I've mentioned previously. I'm going to skip over this slide because I have mentioned what is in and out of scope, but just for a visual for yourselves, it just actually shows quite clearly what is in and out of scope for the review. So although it is a light touch review, we have set some guiding principles for the review itself. Co-production and stakeholder engagement is key. Involvement of stakeholders at all levels and is really essential so that we do have a meaningful engagement and activity to ensure that we're doing the right thing. I've heard some really good feedback today on Marla's information as well, so we want to incorporate all of this new information into our strategy as it's developed. We want it to be outcome focused. I've heard that being mentioned quite a lot today. We want to ensure that our outcomes are clear and measurable and align with improving health and wellbeing of Leicestershire's population. And the strategy review will not just define the commitments, but ensure the impacts are there for achieving them as well. So we will provide the tools and data sets to enable that measurement. So when we report back here, you can see how we're progressing to achieving those ambitions, should we say. Evidence driven, I've mentioned that before. We're going to have utilised JSNA data, engaging with our colleagues from the voluntary sector, using data that they have to ensure that we're providing the right trends in terms of developing our commitments there. Integrating across place and system and place and neighbourhood, so we're aligning our efforts to ensure that joined up approach with public health, social care and other sectors to reduce silos and fostering our collaborations and shared accountability across the organisation. This is really important. Flexibility and adaptability, things change all the time. The needs of our population change. We are reviewing our strategy every 3 years, but we want to have that flex in there that if we do need to add a commitment or review it, we can bring it back to board as part of the reporting process. So we would like to embed and incorporate that into it as well. We're looking at whole population and targeted approaches, so a mix of universal offers and targeted measures as well, as we are doing already. I've already said this before, the life course perspective, it goes without saying. I focus on prevention, so that's already incorporated into our strategy at the moment. We want that to continue and prioritising preventative methods to reduce health risks over time, building individual, community and systems level to prepare for our future challenges. Sustainability and long-term thinking is really linked back to our flexibility. So we want our strategies and commitments to be sustainable and designed with a long-term vision and not too short-sighted and reactive, and considering ever-changing needs. We want to be transparent and accountable, and establishing clear governance structures and defining our roles and responsibilities clearly. We want to communicate our progress openly to stakeholders and the public with regular updates on performance and objectives and targets, and inclusivity, so reflecting diverse voices. So it's really important when we're reviewing that the subgroups not only look at their subgroup membership, but beyond that as well when we're actually reviewing the commitments to ensure that we have got the right stakeholders around the table when we're doing this. I've spoken about governance. I'm just going to explain what the proposal of that looks like. So there will be a core membership. We would like to introduce a steering group for this, really, and we want that membership to be agile, so we're engaging the right stakeholders at the right time. For example, our BI colleagues were quite heavily involved in pulling together our data sets and instrumental to that initial part of the process, whereas our communications and design colleagues will be well, communication will be all the way through, but in terms of designing and pulling the strategies together for this document, we'll be engaging them later in the process. So hopefully this will support in maintaining flexibility and responsiveness throughout the process. And stakeholders for the steering group will be selected to ensure diverse representation. And we would like representatives from subgroups to be put forward, hopefully today, by some of our members here if possible. So the Health and Wellbeing Board will provide strategic oversight for the review and formally sign off the strategy. And once approved, the HWP will also be informed of this. It's proposed that the strategy steering group is initiated, and the steering group will oversee and coordinate the process to ensure all inputs and outputs are aligned, and then all the information pulled together that's fed up from the subgroups are formed into a coherent strategy. It is proposed that the core steering group is co-chaired by appropriate representatives from the local authority and ICB, because it is a joint strategy. So we want to get that alignment at the beginning, really, and appropriate representatives from subgroups and other key stakeholders and subject matter experts to be included. There will be terms of reference for the steering group and to outline its purpose, scope and decision-making authority at that level. We would intend to launch that meeting very quickly if we can, and clearly define the aims and objectives of the review to all the stakeholders, as well as the roles and responsibilities for all the stakeholders that will be involved in that process. So the review and commitments and cross-cutting priorities, as I've mentioned, will be undertaken by the subgroups, with each subgroup contributing to the analysis and recommendations with a clear rationale for any change. We strongly recommend that workshops are done for this, rather than putting it as an agenda item on one of the meetings, because it will probably take longer than an hour to do that if we want to do it properly. And the steering group will help support with that and offer subject matter expertise if the groups so wish. So the steering group will oversee and coordinate the whole process, provide data packs, analytical tools, ensuring inputs are aligned and can, like I said, pulled into the strategy at the end. Just to say what the key deliverables are, we should end up with a new revised joint local health and wellbeing strategy, although it's light touch. We will have revised commitments and cross-cutting themes. We should have updated terms of references and membership. We will develop a comms and engagement plan that will thread through the whole of the process for transparent messaging, meaningful engagement, etc. We'll have a clear implementation plan once the strategy and commitments is approved, including the strategy rollout and progress monitoring tools that will be co-designed by partnership group and partners here. And we'll have those revised data sets as well, provided by our business intelligence colleagues for each subgroup. And if BI colleagues have reached out to you for data, I know some of them have, so thank you very much for providing the data, but if they do reach out for more, please can you engage with them, because it would be really helpful, because we want to get a wide set of data to be able to see where we are at the moment, to be able to assess our commitments effectively. And any impact assessments, previous assessments, EIAs that have been done, will be updated as part of this process as well. In terms of communication engagement proposed for the strategy review, we're engaging with our voluntary sector colleagues. Membership on the steering group will be really important, and engagement with those colleagues as well on our subgroups to ensure that we've got that line of sight to other data and information that they have available as well. We're going to consult with our Health Overview and Scrutiny Committee, and we will inform the HWP of the revised strategy as well. So there are some resource implications for this. It is a joint product of the Health and Wellbeing Board, and we need your time and capacity, a bit of a call out now for you to be able to engage with this review to ensure it is a success. We need allocation of sufficient time for our steering group members and commitment to any sessions that are initiated by our subgroups to be able to analyse this. Internal comms colleagues as well will be required as part of this, and our voluntary sector colleagues as well. And as I've mentioned, our business intelligence colleagues will be allocating a substantial amount of time to revisit the data sets for us. So again, just we need your support, and be ready for us to be launching some of our information soon. Just going to provide you with a really small overview of a snapshot of what the data sets will look like. And Joshua and I had a little bit of a glimpse, and they are looking quite impressive. We've got some infographics, but they are quite simple to be able to interpret. So this slide shows you it's a succinct table showing the indicators, statistical comparisons to England to provide the current benchmark, and you can see the change in direction since the last review, indicating what RAG rating we're at, and it will enable subgroups to see if trends have improved, worsened or stayed the same, to assist with the rationale for change. And there'll be other supporting information, much more detailed than this as well, that will sit behind that. I think there was thematics and all sorts of bits and pieces that they're working on, and they'll be easy to manage. And again, you can have support from the steering group. So the timeline for this, The grey block at the top are really the key meetings that we have. So we've got the Health and Wellbeing Board quarterly meetings. We're proposing that the steering group has monthly meetings, and the ambition is to go to health overview and scrutiny on the 3rd of September before final sign-off at board on the 25th of September, and that will be sign-off of the changes to the commitment. And then if you can see the bottom line where it says delivery, we will then start revising the strategy at that point and rewriting the bits that will be impacted by that. The next section with the arrow in green is the paper that's being presented today to seek approval to the proposed approach sign-off. The next row in dark grey is around the governance. So we've done some stakeholder analysis, seeing who needs to be engaged in terms of this process, the launch of the steering group in terms of reference. And as you see, the governance will be continually reviewed. So if you do notice that somebody should be engaged in part of this process and they're not, please contact us, because we want to engage everybody that needs to be around the table. The next set is really our BI colleagues working on the data sets. We had information since February, so our colleagues have been working really hard to pull that together. And then we've got comms and engagement elements there. And then the main section at the bottom, penultimate line is around the activity that the subgroups will be taking on. So ideally between March and the end of June, we would like the commitments to be reviewed. July and August, starting to pull together those recommendations. And from July to mid-August, writing up those findings, ready for the information to be presented to HOSC and then ourselves at Health and Wellbeing Board. So the recommendations today really is to approve the suggested approach to the strategy review, agree the detailed plan, including the milestones that we've mentioned today, seek support and commitment from partners to input into this work, agree the approach to agile governance, including the setup and launch of a steering group for this piece of work, and recommend that subgroups nominate representatives to be on that steering group as well. And following that approval, the next steps will be making sure we have the right stakeholders around the table. So we'll be getting in touch with you as soon as we can after approval, hopefully, setting up the steering group, production of the data sets so that they're ready to go and be presented clearly to our steering group members, and continuous comms and engagement and governance monitoring. But that's the end of the presentation. So if you do have any questions, I'll be happy, and Joshna and I, to field them. Joshna's here because I wasn't part of the first report. So
thank you. You've done really well, Abby. You know, you've not been in post for long and you've had to get this together. So well done. First presentation as well out of the way. So you're all right. Mike.
I'm sorry, Mike. I'm just wondering, it's probably something to do with what have we got in process? But we didn't know anything about it. Are we brought in with what might happen? Sorry, Mike, I know you don't want to.
There's probably a joint one between me and Joshna. Two ways of answering that. I was going to say, I've got another point, but I was going to say, yeah, should we get rid of COVID-19 recovery to make space for avian flu, which is the point. I suppose it depends whether you want the health and wellbeing strategy to include something about preparing for the next pandemic, in which case there is a whole load of work through the local resilience forum and the local health resilience partners and NHS and council partners around the table around preparing for a pandemic. I guess I'd suggest that's probably more something that would belong to the local resilience forum, but we could at least acknowledge it. Or, well, I suppose that's the point. But I suppose that's different from COVID-19 recovery, where when we were dealing with the impacts of a last pandemic. So yeah, I would ditch COVID-19 recovery. I was going to say the recovery bit is, for me, it's not a title. It's about thinking about what's left. So that thing around Arla's piece around educational attainment and screen time, as I was saying, you could argue that was probably going to happen anyway, but COVID-19 made it worse. So if you actually sort of take COVID-19 recovery off as a title, but said, we need to make certain that the long-term impact of COVID is dealt with via the Children's Partnership, that would deal with that. And then the question is, and maybe Josh, I'll look to you for advice on this one, whether the board want there to be something about health protection and preparedness for emergencies within the scope of the Health and Wellbeing Board.
If to make the public and everybody aware that yes, it's being looked at and it's in hand, and just making people a bit more confident, I think, that even if it's just a small thing in this to say, well, it's the resilient people that are looking at it, yes, it's in hand, we're looking at it, and it won't come and hit us like a brick wall like it did last time.
I think you're quite right, Christine. I think Abby gave that as an example because the decision hasn't been made, and this is where the things will come up. But anyone else?
I think Mike.
Oh, you want to come in again, didn't you?
No, just I think actually it'd be a good idea, because although the work would be going on in another place, there'd be no harm in having it in the Health and Wellbeing Board and just doing a bit of an update on preparedness, and even if it was a chance to talk about what the latest would be, because you're right, on a place level, doing a bit of awareness to the public through the board wouldn't hurt.
Josh.
I think also we've had, I think it wasn't too long ago where the Health and Wellbeing Board had a paper on health protection assurance, and I think we'd agreed that that'd be a rolling plan to do that on an annual basis. So it would be really good to link it in with the strategy, and that's, I guess, what we were wanting to do, to make it more broader about preparedness. Because I guess from a public perception, if you keep COVID recovery, they may think, oh, that was ages ago, and may not see the other work that needs to be done. So I think you're absolutely right, it needs to be broader, and that's why we mentioned it as an example. It was, maybe it's not COVID recovery, it's preparedness, and then the recovery bit could sit under other existing priorities in the strategy.
Rachel.
Thank you. So one of the questions you're asking is around the steering group. So I certainly would support that. I think it would be a really helpful means of making sure that we have that coordination between the subgroups and the work that they're doing. So all of those groups are doing really tremendous work. But I think that in order to identify any gaps within that, or any cracks that we have in terms of, is there an overlap or is there a gap, I think the steering group will be really helpful in identifying that by pulling that data together. I appreciate the fact that it's going to be very data driven. I think it's really important that we use the information that we've got to inform the right thing to do for our citizens. And from an ICB perspective, certainly, I think it would be me in terms of supporting that steering group as the place lead for the ICB. So very happy to do so.
Thank you.
Sorry. I was going to say perfect. Thank you. I've written your name down already.
Ed, please.
Thank you, and thanks, Abby. Really helpful presentation and really well set out and easy to follow. Just to, I guess, emphasise the point that Rachel said, I think the steering group makes sense. As someone who's involved in it last time, it's such an important piece of work and a really important mechanism to kind of shape what comes through the strategy, which has then led so many things to flow from it. So if I can be of assistance in that process again, I'd be very happy to do so. Just a reflection, really, and I guess this is something that kind of sits above everything we're contemplating in local government at the moment, the devolution white paper. There's no kind of reference to that at the moment, and I just wonder whether that's something that we need to just have an eye to. I look at the timescales that are set out in the paper and any choices the government will make about the future size and shape of local government unless you will come next year and after this process. And so I think it's right that there's a business as usual focus right now on getting this done for where things sit right now. But there are opportunities as well, because obviously there's one of the big ambitions around devolution is kind of looking at public service reform and picking up Rachel's point earlier on around kind of integration at neighbourhoods and getting that right. You know, there's maybe some stuff we can do preemptively, whatever choice government makes for the future, about getting that right and working with partners to get that right. And I just wouldn't want to see that opportunity missed as part of this process. So perhaps just need to put that as one of the things that we need to have an eye to, some of those aspirations built into it at the beginning, and that's maybe something for the steering group to pick up going forward.
That's fine. There we go. So last time we did this then, ICBs, I guess, would have been in existence, or emerging, embryonic, 2022, middle of, emerging, yeah. I wonder if it's an opportunity this time around to say a little bit more about ways of working and system, place and locality. And basically, I'd want to use the refresh as an opportunity to codify, if that's the right word, the role of the Health and Wellbeing Board as the place leadership board. And then actually picking up Ed's point, because I was thinking, oh yeah, but things might change with the NHS 10-year plan as well. And maybe it's the language in the best interest of bring oil over troubled water, as you said, looking to my left. You know, whatever the structure, people could quite happily, I think, buy into the idea of system, place and locality. And actually maybe future-proofing is just to think in those terms and get it in our heads and not worry about terminology around county or districts or ICB. So, yeah. Thanks for this. It looks great. I think my only slight caution I've got, or you know, because I always look at the what could go wrong kind of scenarios, is obviously your timeline is tight. And I think when we look at the consultation and engagement activity, yes, we're there. We'll help you. We'll do whatever we can get to get that sort of voices coming through for you. But I think we need to be hitting the ground running very quickly about, you know, who, where, when, because obviously, you know, we're going to have Easter. It's in April. We're then, but by the timeline you've got there for the engagement activity, we'll then be going into peak summer. So I think the quicker than earlier that we can start planning with you about, you know, who is it you're wanting to try and get hold of? How can we help you with it? Where are we going to have those sessions? How we can make sure we're giving a good lead in around publicity and getting people there, the better. That was all really, but I don't think there's anything that can't be done.
Yeah, we have got a risk register, so we're managing the risk around that. But also we have we've got things already in place, not, you know, ready to launch. So hopefully we'll have our kick-off meeting within the next couple of weeks. The data's already been produced. So it's the ambition that we will have our first steering group meeting week commencing the 24th of March, depending approval. Yeah, we've got it all planned. I can't see anyone else wanting to. Oh, sorry, Simon.
Just really quickly to say, fantastic debut, excellent presentation, really good work. It wasn't specifically referenced, but I think it'd be worth building into the plan, not formal sign-off, but a formal requirement for health and other organisations to take the strategy refreshed through their boards. I think it's really important they have sight of it. I don't want to delay the approval, but I think to tie them into the plan, it would be really good to have them going through the board as a matter of requirement. Thanks.
Certainly, we'll do that.
Up in the steering group discussions, I think, so we'll have the right people around the table for that.
Thank you. So we're being asked to approve the suggested approach, agree the detailed plan, including milestones, seek support and commitment from partners to input into the work, agree agile approach to the governance, including setup and launch of the steering group, and recommend subgroups nominate representatives for the steering group. We all okay with that? Thank you. And I will emphasise we do need everybody's commitment. And John said before he went he's supportive. So, but we need, yeah, CQC meeting, I'm afraid. So yeah, if you can share data and you know, give time to it, we'll get a really good review going, and it will be really important to take forward. So thank you. Right, we'll go on to Better Care Fund. Thank you, Lisa, for joining. I know you've had a heavy day today, so thank you.
Thank you. Yeah, sorry I couldn't be there in person. So from Abby, the new person to an old timer, I will, first of all, I'll start with the Q3 return, if that's okay. I'll make this pretty brief because obviously I know we might be a bit pressed for time. The Q3 return doesn't have anything different in it than the Q2 return. Some of the information has changed slightly. I just want to bring members of the board's attention to one of the bigger changes, which is around the update that we normally put in about the metrics. So there are a couple of things to note there on the metrics that you might want to cast your eye over. So we have put how we sit at Q2, because nationally the data when they publish wasn't available for Q3, so we do usually run a quarter behind. As you can see, the admissions metric is running slightly off track. We are still that 0.7% off track on the amount of people that are discharged to their normal place of residence, however still top quartile, so we're not losing any sleep, almost at 92%, so that's working really well. Emergency hospital admissions due to falls is actually meeting target, slightly below at the moment, and we have had a look at the forecasts for 25-26 and we're still meeting that target, which is really good news. So there's some really good focus work there on reducing admissions due to falls. The long-term support needs of older people being met in residential and nursing care home, slightly off target for this one, but this one's the one that changes often when they publish the population data, and so realistically at the moment it could go either way. Generally we do perform quite well on that target, however, so they're kind of the big things to kind of pull out of Q3. Happy, do you want, Chair, would you like me to take any questions on Q3 first, or shall I just launch into 25-26?
Yeah, we've got a question here. Rachel, thank you.
Yeah, not so much a question, more a comment. So around the admissions, I think it's just worth mentioning that our biggest increase admissions has been around 0 to 1 day length of stay. And we're working with our acute trust at the minute, we're working with UHL to identify many of those are not genuine admissions. They are people attending our same day emergency care services, which are in some cases ward based. So whilst we have seen an increase in that, we are doing work to identify which of those are genuine admissions and which of those are related to the growth in our same day emergency care services, which is a positive thing. So it will take a while. It takes a while between setting up the services, running the services and getting the data to catch up.
Thanks for that clarification, Rachel. I can't see any further. Oh, sorry.
No, I was just going to say just one other thing, Rachel. I had, and Simon and Rachna pulled me up on this, nothing gets past them, for Q1. I think, for Q2, I think I'd put in the narrative around the metrics on the template for Q2 that we'd had, I think it was about a 30% increase in admissions. It was actually 11% increase in admissions and a 30% increase in attendances. And you asked me to rectify that. That has gone into the narrative that's been sent and published. So just to pick up on that point.
I did notice that, Lisa, so I saw you'd done that, so no problem. Okay, so we're asked to note that the performance against the Better Care Fund outcome metrics and the positive progress made in transforming health and care pathways up to Q3, and also to note the action taken by the Chief Executive of Leicestershire County Council following consultation with myself as Chairman of the Health and Wellbeing Board to approve the BCF Q3 report and use powers of delegation to approve this for the NHSE submission deadline of the 14th of February. So happy to note that. Move on to item 10. Sorry, Lisa, I forgot to introduce your report last time, but you did, so thank you. This is the Better Care Fund 25-26 planning, pages 163 to 248. This report provides an overview of the progress to date on the draft submission of the Leicestershire Better Care Fund Plan 25-26. And I'll hand over to you again, Lisa.
Thanks. So hoping that everybody's read nigh on 100 pages of report that went into this pack. Hopefully you have. So just a little bit of background then. I won't go into a massive amount of detail in the intro because I'm going to leave it up to you guys as to how much you would like me to give you in terms of information as to where we are at the moment. So on the 31st of January, it was published on the day we had the Living and Supported World Development session, the policy framework and the planning documentation for the BCF for 25-26 was published. That's quite a departure than in previous years where it's been sort of around the April-May time, when we usually had submission deadlines of around July. Our submission deadline is March the 31st, and 2 months sounds like plenty of time, but actually there have been so many changes that we're only really at a point now, 1 month into that deadline, of being at a point where we can actually fill in expenditure and income. So there's been quite a few changes, which is why what I've sent to you at the moment is a couple of the blank templates which have been published, so the demand and capacity modelling and the income and expenditure spreadsheet, but also we have done an initial draft. I wanted you as the Health and Wellbeing Board to see the kinds of things that were in the narrative draft template this time, and also how we are expected to respond to that. I have done some changes because we have another deadline of Monday for our better care managers to receive that draft submission. Our income and expenditure was only finalised last Wednesday. Centrally, they publish, and I don't think we've put these in the papers, but they are available online. They publish the income for each Health and Wellbeing Board against the BCF plan and each ICB. They give us an uplift. In previous years, that's been 5.66% across the board. This year, we have a variation in uplifts. The national NHS minimum contribution to adult social care is being uplifted by 3.9%. The rest has a 1.7% uplift. However, originally there was going to be a 1.7% uplift to the NHS ICB minimum contribution, but there isn't anymore. That stayed static, and instead they have given us back the discharge grant. Originally, the discharge grant for the ICB was subsumed into that minimum contribution. All quite complicated, but I'm happy to talk anybody through at another point the kind of intricacies around that decision making. The long and short of it is that last week we are pretty certain we've had final publication of the finances. The big difference is that there wasn't an ICB discharge grant, but now there is. So all the things that we thought we were going to be stopping, we have now got a bit of wiggle room to continue with some of those contracts. So it's been a little bit hairy, but we have got to a place where now we are discussing the things that we are moving into the local authority discharge grant, because it is the ICB one is £1 million less than it was the previous year. So we are shifting some of those continuous things over into the local authority element, and then looking at the things that we are maintaining. So it's all it feels, again, as always, a little bit last minute. So apologies for that. We are trying our very best to make sure that we get as much information to the board as possible. I am happy to go through the current narrative that I've got rather than the published narrative, or I'm happy to go through the published narrative, or no narrative at all, and I can just go through the cover report and tell you of the things that we're doing at the moment. It's entirely up to you. Which would you prefer?
Well, I think we've got the papers, so if you can give us a brief overview of the things that we've got in that BCF for the public domain, really.
Yeah, that's fine, no problem whatsoever. Okay, so the changes that we've got, aside from quite a tight deadline, the plan for 25-26 has got the same Excel template in it that we normally have, which is around income and expenditure, the same template pretty much around demand and capacity modelling. So those two things largely remained the same. The national conditions which we have to meet have been slightly changed. Plans to be jointly agreed is standard. Implementing the objectives of the Better Care Fund is it has got a slightly nuanced now. You'll notice that there's 2 policy objectives that are in that national condition 2. They link very much to those kind of DARSI recommendations and central government's desire to support the shift from sickness to prevention and to shift from hospital to home. And that includes preventing avoidable admissions. National Condition 3 is about complying with the grant funding conditions, which details what we knew at the time in terms of that increase in uplift, which was 3.9%. There are some changes to that, all of which can be found on the internet via the links that we've provided at the bottom of these pages. Complying with oversight and support processes is National Condition 4 slightly differently. They've asked us to say how we'll be regionally looking at how we share our plans, how we have raised any performance concerns, compliance with meeting those quarterly returns, and also working with other local authority areas and health and wellbeing boards looking at best practice, and also complying with ensuring that we are getting the best out of our Better Care team, who largely are good at providing support to areas for completion. As I said, the strategic narrative is in its first draft, which is included with the published papers. We are changing that all the time, but it's worth having a look through that. Each section of the narrative tells you what they're looking for within each of those returns. So we've pretty much got a really good basis for that. The integration exec at its 4th of February meeting, we went through the Chloe documents for each line and each scheme within the BCF. We've got an extraordinary meeting next Tuesday to finish that off because there are a few that we hadn't received and we wanted to be able to go through the discharge grant elements of key lines of inquiry as well. In the report, I've put what the BCF income is. That hasn't changed. It's still that 57 million. It is split slightly differently, but again, we can update you at the next meeting or in between should anybody wish to know how that might have slightly changed in terms of additional or splits in funding that's been received. The local authority discharge grant has now been pooled into what was the IBCF and is now called the Better Care Grant. So that gives us a little bit more assurance around delivery of that grant. The discharge grant in itself was annual, which made it quite difficult for us to attribute staffing to it because grant funding is largely more capital than it is to be able to be spent on revenue, for example. So that's good. The NHS minimum contribution and the NHS, the ICB allocations also includes now their element of the discharge grant. Neither of the discharge grant elements have had any uplift and neither has the IBCF. So they haven't gone up with any kind of inflationary uplift. The metrics have changed for 25-26. We still have emergency admissions to hospital. We still have the core elements of that, which is around for people aged 65 plus, and it's per 100,000 population. So that largely remains the same. There's an additional metric around the average length of discharge delay for all acute patients. That comes from 2 elements, which is proportion of adults patients discharged on their discharge ready date and the average number of days from discharge. They've also maintained the long-term admissions to residential care home metric as well. In addition to the 3 metrics, there are now 6 supporting metrics. The publication of the BCF return isn't dependent on the supporting metrics. However, we will be doing some work to make sure that we have got an alliance across our system with some of those supporting metrics. So, for example, we're utilising information from UHL around criteria to reside. We're making sure that that's aligned to our discharge metrics and the supporting metrics that are around the discharge ready date, for example. You can see those on the report at 28. There are 6 bullet points there that tell you which of what these 6 supporting metrics are. There is, again, the intermediate care and demand and capacity modelling plans, which we haven't began yet, but they will form part of how our narrative is shaped around that. And there is a specific section around intermediate care within that also details how we're using the demand and capacity modelling to shape our services. I just think that's roughly about everything that we've covered so far. I'm happy to go through that cover report, or if you'd prefer, we can just take any questions. It's entirely up to you.
Mike's got a question here.
So, bit of a question, I think. It's always it's always the same. It's not blaming you, Lisa, but there's always a job on, isn't there? Which is guidance come out, and then it's helpful ever to try and turn around the submission, and the integration exec does its job, and then John signs it off, and it comes to the board. If we were to sit down with the guidance and assume that the guidance somehow miraculously stayed the same next year, and had a more kind of art of the possible conversation in the middle of the year with Health and Wellbeing Board, would we come up with something different? Would it give us the chance to start with a blank sheet? You know, I'm not saying there's anything wrong, and I don't even know if there would be a different answer, but I suppose it would be lovely to almost, in the absence of DHSC giving us the time to think about what we wanted to achieve from first base, can we lever that time in ourselves?
Yeah, it depends on what it is that you want to lever. So it goes back to all the conversations that we ever have about the Better Care Fund and actually the staticness of that funding. It is around core services. What we do in the integration exec around those CLOEs is to say, that's great, we're happy with that, but actually we could do it better, or we could do it better with these opportunities over here, or we could do it better, you know, if we linked in with this service which is delivering something very similar. So there is always that conversation to be had, and we generally do still always have that in year where we can. The problem is how it links to the policy framework, isn't it? Like you said, this year is quite different. It's quite a departure. It is linked to the kind of central government, the Darcy report, where they're going direction-wise with NHS and adult social care. It links to that in quite obviously with the two core principles within one of the national conditions. Would I have guessed that? Probably. Could we have developed? Yes. But the good thing is that Abby and Abby's just done a presentation based on the joint health and wellbeing strategy. I'm looking at my return and I'm thinking to myself, actually, there's not an awful lot missing. I took, Simon can tell you, and he can verify this, through our IDCG meeting this morning. I took them all through the current revised draft, and we have a specific, very first section about priorities is on the neighbourhood models of care, which is all links to your joint health wellbeing strategy and the discussions that I've just heard around that work. So there's nothing in there, I don't think, that would leap out at me as saying we missed that ball, we missed that opportunity. That notwithstanding that, you know, always happy to have a conversation with the Health Wellbeing Board mid-year to challenge ourselves about whether we're actually meeting that condition, or whether we're, you know, looking to shape things slightly differently or do things slightly differently. I will say policy is always quite easy to retrofit to anyway. You know, I don't think they're going to put anything in the policy that is massively out there. Does that answer your question, Mike?
Sorry. I think so. I guess maybe it's that opportunity mid-year, not so much to sort of think, is there anything wrong with what we're doing? And the answer would be no, there's nothing wrong with it. But I suppose it's keeping abreast, I'm sure you would have been. It's almost like, is anybody else doing innovative stuff that we hadn't thought of that we might want to consider? You know, it's almost kind of keeping abreast of what's going on nationally and good innovation.
Yeah.
Say, make it quick, because Joshna's flaming you now for forgetting her name.
Do you know, all I could think of was Rachna, and it wasn't. It's Joshna, and I'm sorry, Joshna. Please forgive me.
I did have a quick chat with John just before the meeting about, you know, Health and Wellbeing Board members not being able to have any input earlier to, you know, they often we're having signed papers coming. We've talked about this before, Lisa, and John was up for having a discussion, you know, workshop or whatever in the summer. We won't necessarily know what the next guidance is for the next year or how long it's going to be, but we can do that looking at things and seeing if there's other things we want to perhaps add in or you know, change or whatever prior to you actually having to do all this rushed work to get everything through on time. So I think Health and Wellbeing Board members would appreciate that. And I know a couple of things came out of integrated exec where there's not been enough time this time to really look into it. But if we can plan something in for the summer, we're ahead of the game then, and at least Health and Wellbeing Board members have had a influence. Is that okay?
Yeah, absolutely fine.
Thank you.
If we do that, it'd be really good to head that up with what is the art of the possible within the BCF. You don't get the opportunity to re-spend 84 million every year differently. It is largely tied up, and I would welcome doing that with the so one of the things that we do mention in that draft report is that our focus is very much on community and prevention, and we have quite, you know, majority of 70% of the budget actually goes towards that. So I think we'd probably still want to maintain that element of ensuring that we've got our focus around community and prevention, and then largely the rest is intermediate care.
Yeah, I just think when we had that development session and we had some good thoughts come out of that, and it would be nice for that to be somehow fed into the discussions around it rather than it just to be left up in the air. So I think that would be really good. Thank you. I'll have to leave that in other people's hands, I'm afraid, but at least we've decided here. So I've got no more. Oh, sorry, Kevin, come in.
Hi, Lisa. Thank you very much for this and for the very quick but very good whistle-stop tour we've had from you about what, you know, what's here and what we need to be thinking about. It was just a very quick point of clarification. Appendix A on page 171 of the pack that we've got, has that been submitted yet?
No.
So for point of reference, can I just be a bit cheeky and say, when you referencing us, can you take out Leicester? It's Voluntary Action Leicestershire.
Okay, yeah, no problem.
It was only that point. It's
will do.
That's brilliant.
Yeah,
thank you very much.
That's great. Thank you.
Thank you. So we're asked to note the content of the report, note the draft narrative document attached as Appendix A that details the proposed contents of the BCF plan return, authorises the Chief Executive of Leicestershire County Council, following consultation with myself, to finalise the plan before the national submission deadline of the 31st of March, and note that the members of the Integration Executive at its meeting on the 4th of March will be asked to indicate their support for the plan ahead of the final submission to NHS England. We're all happy with that? Yeah. The date of the next board meeting will be held on Thursday, the 29th of May at 2 o'clock. And I think we probably need to just make sure people realise that they're 2 till 5, because a lot of people are only putting 2 to 4 in their diaries. So if we could make sure that's sorted for next time. Any other items which I've decided to take as urgent? We have none. So this is my last meeting of the Health and Wellbeing Board. So I'd just like to thank everyone. I've really enjoyed working with you all, and I hope you feel I've made some difference whilst I've held this office, and I wish you all well, and we'll watch from the sidelines of what you do going forward. So thank you very much for attending. Oh, Mike.
Yeah, you beat me to it, because if you weren't going to say anything, I was, because obviously it's the last Health and Wellbeing Board before the election, and therefore your last Health and Wellbeing Board as chair before you stand down as a county councillor. But you've just said it. But I would just like to echo on behalf of the board, thanks for your chairing and your leadership over the last 4 years. And it's always like you set things up and then somebody else will get the credit. And I suspect the answer is that's where we're at. I think we're getting to a good place, particularly with the place-based team work, but your contribution to the whole thing and the mental health subgroup's been really well appreciated. So you, and if we can we put on record on behalf of the board our thanks to Louise.